So let's start and talk a little bit about the guidelines. It's always a good idea to talk about guidelines. I picked the European guidelines, not that I have anything against the American College of Cardiology, American Heart Association guidelines, but they're a bit out of date and need updating, and those organizations are planning to do that. But here are the ESC guidelines, which I think are terrific. And really at the top here is a 1A recommendation for a LDL goal of less than 55 milligrams per deciliter in patients with chronic coronary syndrome. So that's patients with coronary artery disease. So that is more aggressive than the US guidelines. And furthermore, also then as a level of recommendation that they mention, if patients, while they're on intense LDL-lowering therapy, have a second vascular event within 2 years, there the guidelines actually allow the use of a target of less than 40. That is given a 2B level of recommendation, but I still think it's important to realize that it's there. I mean, in my own practice, I do, if the patient's already on intensive LDL-lowering therapy and still having events on that, despite being adherent, despite documented low LDL, then I do usually intensify. So I think these are really good guidelines, and would encourage you to read them. But regardless of what we're thinking or talk about guidelines, this is some recent work from one of my fellows, actually, Dr. Agarwal at Brigham and Women's Hospital, looking at the question of what are we doing in the United States. This is looking at adults with coronary artery disease. Just came out in JAMA about a year ago, and found that only 1 in 4 patients, adults with documented coronary artery disease, is meeting the ACC-AHA guideline of less than or equal to 70 milligrams per deciliter. If we went with the European guideline of less than 55, only 1 in 10 is meeting that goal. So that's pretty bad. And sometimes doctors say, oh, well, that's because these drugs are expensive and PCSK9 inhibitors are expensive. But the use of ezetimibe here was 7%. So that's a generic, well-tolerated, safe, cheap drug. So drug cost might contribute to some issues, but this is really more fundamental. It's even just generic statin and ezetimibe that are being underutilized. Well, perhaps one strategy to get intense LDL on board quickly would be to initiate PCSK9 inhibition in patients when they're with us with acute coronary syndrome, sort of like we do with aspirin and a P2Y12 inhibitor. Some people also initiate high-dose statins on presentation. Maybe we should be doing the same thing, if not on actual presentation, prior to discharge with the PCSK9 inhibitor. There's some pilot data certainly suggesting this is safe. But is it incrementally effective? Well, the EVOLVE trial is ongoing. One of our subsequent speakers, I don't think he's here yet, Dr. Banaka, will be talking about a different topic later today, peripheral artery disease, but his group, CPC, is helping coordinate and lead this trial. But at any rate, EVOLVE is taking patients with STEMI or NSTEMI, about 4,000 of them, and randomizing them to either usual care or starting the PCSK9 inhibitor evolocumab in the hospital prior to discharge. So potentially, this might show, at a minimum, better adherence than we've seen to PCSK9 inhibitors and intense LDL lowering strategies in general, and perhaps even incremental efficacy from starting sooner, either from just better adherence or really early potent LDL reduction in this context. So in a few years, we'll see what the results of this are. Moving beyond that very acute setting, some other trials that are worth keeping an eye on include the following. Victorian to Prevent, that Professor Stegg here is actually leading. This is a phase 3 trial of inclisiran versus placebo in the secondary prevention universe to see if it reduces major adverse cardiovascular events. And if it does, then it means we probably should be adding PCSK9 inhibitors to the usual mix in a very broad segment of secondary prevention. And a little bit less mature in terms of timelines is Victorian 1 Prevent that I'm happy to chair. This is a primary prevention study of inclisiran versus placebo, 14,000 or so patients. We're also looking at major adverse cardiovascular events to see if people, maybe like many people in this audience that aren't overtly sick in any way, but have atherosclerosis brewing, so high-risk primary prevention, I would say, should be on more than just generally good medical therapy and statins and that sort of thing, and should they get an injection every 6 months to lower their LDL to very low levels, or in this lower risk population, is a statin just good enough? So it'll be a few years before the results of this trial are out as well, but we'll hopefully expand our understanding about how aggressive we should or shouldn't be with respect to LDL in the primary prevention setting. And the final trial in this category I'll mention, one that just got launched a few weeks ago here at Mount Sinai. This is the other 2 or 3 trials I mentioned are all multi-center, multinational trials. This is just a Mount Sinai Fuster Heart Hospital trial that we're doing within our health system, this hospital and all our other campuses. This is the pre-CAD trial that Dr. Fuster is leading. And here the idea is taking young folks, as he was talking about in his lecture, and seeing if really intense preventive therapies, including inclisiran, help reduce plaque progression. Now, in young people, we can't do a trial powered for cardiovascular outcomes. I mean, we could, but it'd be, 10, 20,000 patients followed for 10 years, hard to fund that sort of thing. So here, really the endpoint is using 3D vascular ultrasound, looking at the plaque and looking for plaque progression, or hopefully not, if they're on intense LDL and other risk factor modifying therapy. So just got off the ground. And for those of you that are in the Mount Sinai Health System, we'll further get the word out, and hopefully you can enroll your patients in this trial. Now let me move on from LDL to triglycerides. These are some data from the REDUCE-IT trial, which showed that icosapent ethyl reduced cardiovascular events in secondary and high-risk primary prevention, really broad population of patients, but all of whom had triglycerides greater than 135 milligrams per deciliter. Here's some subsequent data from that trial from our preventive cardiology fellow here at Mount Sinai, Dr. Gurvitz, looking at reductions in large MI. So it turns out icosapent ethyl does prevent the small MIs, but if anything, it also prevents the big MIs, with a hint that perhaps there's even greater effect sizes when you're getting into the larger MIs. And other data from REDUCE-IT as well, mechanistic data, a mediation analysis, seeing how does it work. We studied patients with elevated triglycerides. The drug lowers triglycerides, but that's probably not the predominant mechanism of action. And this corroborates that statement. About 2/3 of the benefit of icosapent ethyl really is from the increase in EPA, or icosapentaenoic acid, and a corresponding decrease in arachidonic acid, reflected by the EPAA ratio. So that accounts for 2/3 of the clinical benefit. The reduction in triglyceride, or triglyceride-rich lipoproteins to be specific, also does account for some benefit, but it's a sliver of the benefit. And then a very, very small fraction of the benefit is due to just a bunch of other changes in biomarkers. And about 15% of the benefit is due to, we don't know. That is stuff that wasn't measured and therefore can't really comment. But the take-home message is of the 25% reduction in first events, the 30% reduction in total events, about 2/3 of that is just due to the EPA and not due to other stuff. So some insights about that. There's other work going on in the world of triglyceride reduction. That is, not every drug that reduces triglycerides reduces cardiovascular events. Icosapent ethyl did. The fibrates, other omega-3 fatty acids, mixtures of EPA, DHA did not. But nonetheless, there are a number of trials of totally different therapeutic approaches to reduce triglycerides. And one of those is looking at FGF21 analogs. I imagine many people in the audience haven't heard of FGF21, but it's involved in lipid and glucose metabolism. It helps regulate energy expenditure, effects on fat, muscle, the liver. And it has been studied in a phase 2 trial. We published this work recently in Nature Medicine that showed that pegozafermin versus placebo lowered triglycerides by a lot, by about 50 to 60% at these doses here. So a very effective drug for patients with really elevated triglycerides, maybe useful to prevent pancreatitis or things like that. Maybe or maybe not useful for reducing cardiovascular events, since the phase 2 trial was empowered to look at clinical events. But we did, in a sub-study, look at patients on pegozafermin or placebo. It was an 8-week study, pretty short-term study. Shown here are MRIs of the liver at the top, placebo here, different doses of the drug on the right. And if you're not familiar with looking at this, green, yellow, red, orange are bad, blue is good in terms of fat content in the liver. So first of all, what we found, and these are truly representative samples, all the patients' images are published in the supplement, so I'm not just cherry picking the best images here. First of all, these patients with elevated triglyceride all had a ton of fat in their liver, something that really previously hadn't been well appreciated. So if you have patients with hypertriglyceridemia, obviously if it's above 500, there's a risk for pancreatitis. If it's above probably 100, there's a risk for atherosclerotic disease. But what really hadn't been appreciated is there's a risk for liver disease, fatty liver. So when you've got patients with high triglycerides, of course, think about pancreatitis risk, think about cardiovascular risk, also think about liver risk, because this, of course, is a silent process until it's not silent and the liver is fibrotic and cirrhotic, and at least historically we've believed then it's too late at that point. But at any rate, you can see what happened in placebo at the top and at the bottom after 8 weeks. It goes from green to green. There's no difference on placebo, of course. But here you can see with these different doses of pegozafermin, the liver over just 8 weeks goes from green to blue. So in vivo evidence that the liver is getting rid of fat because of this drug. Does this mean anything clinically? Well, this was 8 weeks. It was a small sub-study. We didn't really have the ability to look at clinical endpoints, but there was another trial published in the New England Journal of Medicine, same drug, where we did look at the liver. This was a trial led by liver doctors, and what was found in that study, it's published in the New England Journal, was a significant improvement in fibrosis, and in a significant proportion of patients, even resolution of what used to be called NASH, non-alcoholic steatohepatitis. So this was over 24 weeks. So what previously many of us thought couldn't happen, that is, the liver's fibrotic, oh well, it's too late. It looks like it might be a reversible process and over a relatively short duration of time. Phase 3 testing is starting both for the triglyceride potential indication, but also in cirrhotic and fibrotic but non-cirrhotic liver disease. So hopefully we'll see in a few years exactly what this approach to lowering triglycerides could do, including for liver health. And I'm just going to quickly make a comment here because I think much like cardiovascular specialists have moved into diabetes, so to speak, that is, many of us care for patients with diabetes using drugs that used to be thought of as drugs only used by people directly caring for diabetes, becoming involved in trials of agents that historically have been thought of as diabetes drugs, like the SGLT2 inhibitors and GLP-1 agonists. I predict the same thing will happen to liver, where cardiologists encroach into that area in a good way for patient care and research, because there's a lot of overlap between cardiovascular risk factors and risk factors for fatty liver. And the terminology has changed. It used to be this NAFLD or NASH, and now it's MAFLD and MASH. The M is really referring to metabolic dysfunction-associated steatotic liver disease or metabolic dysfunction-associated steatohepatitis, MASLD and MASH, respectively. But more important than just the nomenclature change is really raising awareness of these conditions, because they're highly prevalent in patients with cardiovascular risk factors. I showed you, for example, with elevated triglycerides, basically. All the patients we studied had fat in their liver in a substantial amount. So I do think, much like we're doing a lot more in terms of prescribing drugs for diabetes as cardiologists, the same will happen with respect to assessing liver-associated risk. Let me move on now to Lp(a). I threw that in the category of lipid-modifying therapies because I thought it deserved to be there. And there are 3 trials that I'll mention that are ongoing. There are other trials as well, but these are 3 large trials: Lp(a) Horizon, looking at pelacarsen; Ocean-A, looking at olpasiran; and Acclaim Lp(a), looking at lepidosiran. And these are all trials randomizing patients to Lp(a) reducing drugs versus placebo on top of good background medical therapy. And you can see the estimated study completion. Some will report out hopefully in the next couple of years. Some are a little bit further along. And we'll see whether this strategy is indeed incremental to LDL lowering. Early on, for those of you that were here in the audience or online, we discussed the importance of really aggressive LDL reduction in people who have concomitant Lp(a) elevation. Of course, you should do that. But beyond that, should you specifically target Lp(a)? It's an independent risk factor for cardiovascular disease, but is it a modifiable risk factor? This series of trials will answer that definitively, so we'll know in a few years. But as was alluded to before, personally, as the European Society of Cardiology guidelines recommend, I think everybody should at least once have Lp(a) measured in their life because it's believed to be, highly genetically determined. Although I must say in my own practice, I've measured Lp(a) for years. I've noticed when you repeat it in patients, and I'm not saying you should repeat it, the European guidelines just say measure it once, that there's a fair amount of variability, and there's just a publication about that a few weeks ago. So it may not be as fixed in time as we think, and probably like everything, sure, genetics matters, but maybe other things matter a bit too, like lifestyle. The National Lipid Association in the U.S. has also rather recently recommended Lp(a) testing in everybody. So something you should consider in your patients. To wrap up a couple of slides, I just want to summarize a few things. This is from not actually a guideline, it's sort of a white paper or a consensus statement that a bunch of endocrinologists and cardiologists and primary care physicians, other specialists put together, headed by Yehuda Handelsman, who's an endocrinologist. First of all, just saying that, we should monitor lipid levels probably about every 6 weeks or so until the target is achieved. I think a lot of times what happens, this is particularly prevalent in primary care practices, patient comes in, LDL's, elevated, and there's, let's try lifestyle for a few months and come back in, 6 months or a year or something. And that's good to recommend lifestyle, of course. Dr. Blankstein was endorsing a plant-based diet, as I would endorse as well. But in real life, that doesn't usually do the trick that patients actually lose weight and start exercising a lot and alter their diet drastically. Should still try, but oftentimes pharmacotherapy is needed, and it's important really to make sure that you follow up with the patients quickly, initiate pharmacotherapy when appropriate, but then follow up and make sure that the targets are reached. Some guidelines from years ago had done away with the LDL targets. That was a huge step backward. I think there's still folks in primary care that sort of learned the lesson from that guideline and then didn't realize the guidelines reverted and said, no, of course you need to measure and make sure that you're achieving targets. And different guidelines have different numbers. I showed you the European guidelines, but at least what we thought was that an LDL target should be less than 100 in folks that have 2 or more risk factors and a 10-year risk of less than 10%, diabetes or CKD, and stage 3 or more with no other risk factors, or a CAC score of less than 100. In these sorts of folks, we still think of them as high risk and said, shoot for an LDL of less than 100 in these, what I'll call primary prevention patients. In folks that are very high risk, there we said, go for an LDL less than 70. Here it's a 10-year risk greater than 10%, in diabetes or CKD, greater than or equal to stage 3 with 1 or more risk factors. CAC score greater than 100, so as you can see, going from sort of not that much in the way of risk factors to more risk factors. Also in here is heterozygous FH, but without atherosclerotic cardiovascular disease. Some people might be more aggressive there than that. And then for extreme risk, we said less than 55, so that's established atherosclerotic cardiovascular disease of any of the vascular territories, not just the coronaries. CAC score greater than 300, which, some observational data, I think Dr. Blankstein may have referred to that from Mason and other places, suggests CAC score greater than 300, probably that's putting you in a range of risk that's a secondary prevention type patients. Diabetes with target organ damage, again, CKD, 3 or more in terms of stage with albuminuria, heterozygous FH, with a family history of premature atherosclerosis. So, in that sort of situation, we said less than 55. In extreme plus risk, we actually recommended less than 40, sort of akin to the European guidelines, where there's progressive atherosclerosis despite the LDL being less than 55. And, lots of options for doing this, things like statins, PCSK9 inhibitors, the monoclonal antibodies in particular have outcome data, as do statins, ezetimibe, bempedoic acid, and the combination of bempedoic acid. So, things that have outcome data, as well as things such as PCSK9 inhibitors with the siRNA approach, inclisiran, where there you do have the advantage of doing it every 6 months, but no outcome data yet, though, as I showed you, lots of outcome data that are accruing. have to see what it shows. Things like the bile acid sequestrants, probably no one in the audience is using, but other options in lipid specialty clinics. And then hypertriglyceridemia, finally, I'll mention. I don't know that I necessarily call that a target for therapy for cardiovascular risk reduction per se as a general strategy. Certainly if someone's in the range of greater than 500, there's a risk for pancreatitis, and there, you want to use things like icosapentaethyl, fibrates, could consider other omega-3 fatty acids at a high dose, 4 grams a day, or even niacin, though that's largely fallen out of favor because in other contexts it hasn't really provided cardiovascular protection and raises side effects. I mean, I would favor IPE here and adding a fibrate myself. Obviously, diet, alcohol avoidance, weight reduction, being on a maximally tolerated statin, all important in that particular setting. Now, in terms of reducing cardiovascular risk, say in folks with triglycerides between 135 and 499, or I'd say even higher, for the purpose of reducing cardiovascular risk, other than diet, weight reduction, maximally tolerated statin, the only evidence-based approach at this point in time is icosapentaethyl. Other things to consider for patients with insulin resistance, you might consider adding pioglitazone in patients with acute severe hypertriglyceridemia. There, if you're managing such patients, you'd consider insulin, maybe even apheresis in more extreme cases. And just to put into context what the expected decreases are in triglycerides, with statins, you get about a 20 to 30%, fibrates about a 30 to 50, omega-3 fatty acids about 30 to 50, niacin about 20 to 30, pioglitazone about 10 to 15. There are a lot of other trials. For the sake of time, I didn't include that are looking at different triglyceride-lowering strategies. So I think in the future we might have additional therapeutics that target patients with elevated triglycerides that may or may not reduce cardiovascular risk and may or may not be working primarily through the triglyceride reduction. A lot of those molecules have multiple mechanisms of action. But in a nutshell, really those are the key points about LDL and triglyceride lowering. With that, I'd like to wrap things up. Thank you very much for your attention. If